Hello, this is Dr. Frances Munroe, and I'm here to talk with you today about pediatric endocrine disorders. These are some slides that I updated from a previous lecture done at George Washington University at the School of Nursing. There are several endocrine conditions that we're going to speak about today. The first is congenital adrenal hyperplasia, type 1 and type 2 diabetes, growth failure, otherwise known as failure to thrive, some disorders of puberty, and thyroid disease. When we talk about endocrine disorders, it's very important to detect them as early as possible. One of the main reasons that we have newborn screening. Two of the most important diseases we screen for are PKU and thyroid disease. We continue regular screening of children for any disturbances of their growth and development throughout infancy, early childhood, and adolescence. We want to pay particular attention to the onset of puberty and the progression of puberty to adulthood. And lastly, we always want to educate parents regarding any early signs and symptoms of diabetes. One of the ways that we monitor children right from birth until adulthood is through the growth charts. You can download these from the cdc.gov website. And at each well child visit, it's very important to monitor both their height, their weight, the head circumference in infants and small children, and BMI as children get older. We want to look at the evaluation of different patterns of growth and compare these to their family's growth patterns. In puberty, we look at certain stages called Tanner staging that we perform on all adolescents. It's very important as a guide of the normal sequencing of reproductive hormones. In this way, we can compare and see what are the normal variations from any possible pathology. As you can see by the graph, just the chart of stages of puberty for girls from breast buds to full breast development, which takes almost 12 years for complete development. For thyroid disease, the newborn screening is the most important. The incidence of thyroid disease overall is very small in childhood other than congenital thyroid disease. However, starting in adolescence, we need to be aware of the increased incidence of Hashimoto's thyroiditis. The symptoms of Hashimoto's thyroiditis, which results in hypothyroidism, are very similar to adults, with some developmental interpretation. A congenital thyroid deficiency occurs in about 1 out of every 4,000 infants, more common in females, and can be caused by either improper development of the thyroid gland or hereditary enzyme deficiencies. Newborn screening should at least include thyroid testing, measuring T4. If this is low, a TSH is checked, usually at greater than 24 hours of age, and in some states, they'll check it twice before discharge. PKU levels, usually greater than 15 grams per DL, and they usually screen for this after the initial feeding. Repeat screen is done usually 3 days. There's a huge variation in which type of metabolic screening tests are done, and this varies by state. I encourage you to check with your state to see what that policy is. Usually you can go to the Department of Health online and see what types of testing is done. Some states are checking for galactosemia, sickle cell, maple syrup urine disease, just to name a few, cystic fibrosis. When we look at congenital thyroid deficiency in particular, some of the signs and symptoms might be a prolonged neonatal jaundice, a lethargic baby, delayed stooling because of constipation, poor feeding, a low hairline, coarse features, mottled or cool skin, slow growth, sluggish reflexes, delayed development, and almost as severe as mental retardation. Acquired hypothyroidism, as we mentioned earlier, in adolescence, you may start to see Hashimoto's thyroiditis. There can also be idiopathic reasons or hypothalamic or pituitary disease. Some of the signs and symptoms of acquired hypothyroidism would be enlarged thyroid or goiter, a slow growth pattern, decreased energy, lethargy, decreased appetite, increased constipation, cold intolerance, changes in the hair, the skin. And if they're greater than 2 years of age, usually you do not see any mental retardation. What are the common labs that are drawn for thyroid disease? And if you remember from the adult lecture, that would be the same, the TSH, the T4, and the T3. Usually in children, we will get the antithyroid antibodies also. And treatment for our children is the same, with replacing the endogenous thyroid hormone, usually with the use of levothyroxine. Of course, the dosage is calibrated both by the lab work and changes frequently with increases with their growth. Most thyroid disease, as with other endocrine disorders in children, are managed by the pediatric endocrinologist, but it's important for us to be aware of the changes and attuned to any new developments with the children in our practice. Some of the ambiguous gender states would be true hermaphroditism. You may also see a congenital adrenal hyperplasia, which is an enzyme deficiency characterized by excessive androgen production. Can result in ambiguous genitalia in females. Prescription for therapy would be to replace those missing hormones, surgical correction, and of course a lot of family education and support is necessary. With congenital adrenal hyperplasia, they cannot produce cortisol or aldosterone, and males may go unidentified for a long period of time. It is a salt-losing disorder, and you may notice a failure to thrive, again checking those growth curves. You may see dehydration, electrolyte imbalances, checking basal metabolic profile, and lifelong medication is required. This is a nice chart showing the interactions between the mineral corticoids, the glucocorticoids, and the sex hormones. And as you can see, the differences and the things that need to be replaced. When we look at specifically failure to thrive, this is checking the growth curves along with a detailed history and physical of the child, looking at the interaction between the parent and child, feeding practices, assessing the parent's knowledge base. Is it a first-time mom or dad? Do they get support from friends, family, the grandparents? A detailed dietary history is very important, and whether or not the child has feeding difficulties at other people's houses, the family, the friends. Some of the most common organic causes of failure to thrive would be renal disease, cystic fibrosis, or celiac disease. Short stature is another problem dealt with in pediatric endocrinology, usually late growth and puberty. It can also be caused by a growth hormone deficiency, and it is very difficult to differentiate unless there's a very clear family pattern, and it can be very much a psychological problem for young boys and men. Again, referral to endocrinology for testing for growth hormone would be especially important. Some of the disorders that we see with puberty relate to either the early onset of puberty or delayed puberty. So there are many normal variations. A lot of times this runs in families. It's very important in the history, for example, to check with the mothers and fathers to see what age they went through changes, what age of menarche, what age that the fathers noticed changes in puberty and their growth spurt. Also checking for any gynecomastia in males. Precocious puberty is defined as puberty occurring less than 8 to 9 years of age. There can be multiple causes for this, so again, important to refer to endocrinology. And it can produce premature closure and a reduced final height, so it's very important to diagnose this and try to delay this if possible. Now, with delayed puberty, consider exercise as a cause in females. Again, the female athlete triad and possible anorexia. If menarche has not been achieved by age 16, it's very important to get a consult both with endocrinology and GYN. Tanner staging is very helpful with assessing changes in puberty, and it's usually divided into 5 stages. And the described changes are external signs of normal development of the endocrine system as the child is maturing. In females, this would include breast development, physical growth, development of pubic hair, and the first stage of their menses, known as menarche. In males, this would be growth of the testes, growth of the penis, development of pubic hair, and physical growth. This chart shows some comparisons of Tanner staging for girls. You can see the earliest changes are usually the breast budding and the start of pubic hair. The height spurt occurs usually around average age 12, and then usually with the start of menarche, you'll start to see a drop-off in the height, usually within a few years of the age of menarche. When we look at boys, the first changes are usually with growth of the testes, followed by development of pubic hair. The genital ratings are stages 1 through 5 on the Tanner stage, and you can see how that corresponds to both height and growth and development. Again, usually the height spurt peaks around age 14, and then you see a slowing of the rest of the growth and development after that. A short summary about Tanner staging. If you look on those previous slides, you could see the differences in the growth spurt between boys and girls, with boys about 2 years behind. Also differences noted in pubic hair development, which is about greater than 1 year behind in boys. With girls with breast budding and pubic hair development appearing just as growth begins to accelerate, and then the onset of menses appearing in the later stages, as I mentioned, after the major growth spurt. One final note is that in boys, the growth of the testicles is the very first step in maturation. Thank you for your kind attention. This is the end of today's presentation.